Hi, good afternoon, everyone. Sleep apnea surgery has grown by leaps and bounds over the last 30-40 years. There are many advances in sleep surgery that allows us to bring better outcomes to our patient. I'd like to thank Professor C for giving me the opportunity to share this with you in this Vietnamese Sleep Medicine Society annual conference.
I have no conflict of interest to declare. The late Christian Guilleminault coined this term obstructive sleep apnea, and we know that it is characterized by repetitive upper airway obstruction, oxygen desaturation, arousals, sleep fragmentation, and is a spectrum of disorder ranging from snoring to upper airway resistance syndrome to frank obstructive sleep apnea. In the 1979 and 1981, two important treatments developed. Those two form the foundation of medical and surgical treatment till today in the treatment of obstructive sleep apnea. One is the evoluopalatal pharyngoplasty, where Fujita brought back from Japan after learning from Ikomatsu, and Colin Sullivan from Australia, who developed this continuous positive airway pressure machine. You would have known by now that sleep apnea is associated with medical consequences like ischemic heart disease, stroke, hypertension, increased mortality, as well as poor quality of life, sleepiness, and motor vehicle accident. And the risk of mortality increases with the severity of sleep apnea. It is estimated about 1 billion people in the world have sleep apnea, and that is about 1 in 7. We know that the first line in the treatment of sleep apnea is medical treatment and device-based treatment. We can use positive airway devices, mandibular advancement splints, weight management, positional treatment, and sleep hygiene to treat a lot of these patients. Unfortunately, CPAP compliance is generally poor. About 10% never received a CPAP upon diagnosis. 5 to 50% of patients reject a CPAP within the first week. 12 to 25% of remaining patients discontinued CPAP after 3 years. And in our own Singapore experience, we know that adherence and compliance are poor. Perhaps they don't want to look like this nor this. So are we happy to leave patients untreated? Obviously, the answer is no. That's why in 1984, William Dement, Christian Guilleminault, Nelson Powell, Robert Riley came out with this Stanford phase protocol. Well, they felt that at the time, UPP is excessive and tracheostomy shouldn't be the only treatment available for this group of patients. Since Powell and Riley used the phase protocol to treat patients with sleep apnea, there are many advances in this field over the last 10 to 20 years. From drug-induced sleep endoscopy, which allow us to visualize the airway during sleep, to changes in concept for palatal surgery as well as tongue surgery and skeletal surgery. And now with the newest kid on the block, hypoglossal nerve stimulation, we have more surgical treatment that we are able to use to treat our patients. Let's talk about drug-induced sleep endoscopy. Essentially, it is an assessment of the airway during drug-induced sleep stage. So essentially, we can either give midazolam, propofol, or dexmedetomidine to sedate the patient to get them into sleep, or we assess them to see where we can treat the patients or where it needs to be treated. There are two classifications that are used commonly, the VOTE classification as well as the NOHL classification. The VOTE classification, we are talking about the venopharynx, oropharynx, tongue-based, as well as epiglottis obstruction, and whether or not we see complete or partial obstruction, and whether there is fluttering or snoring. In the NOHL classification, there's the nose, the oropharynx, hypopharynx, and the larynx. And all this will tell us where we need to treat. And what studies have shown is that sleep apnea is a condition that affects the entire airway. It is never one isolated level of obstruction. Most of the time, there are a combination of obstruction that is affecting the patient. And with this targeted assessment, we are then able to target the area of obstruction and choose our surgical treatment accordingly. Now we're going to talk about palatal surgery, which has seen a shift from ablation to reconstruction over the last 10 years. Palatal surgery continues to be the workhorse of sleep apnea surgery with many publications since 1981. If you look at the literature, you'll see many published studies on improvement in polysomnographic data, sleep parameters resulting from palatal surgery, improvement in snoring, ESS, quality of life, hypertension, even mortality data, and cost-effective analysis data. Since Fujita used UPPP to treat obstructive sleep apnea in 1981, this surgical procedure has undergone many changes and modifications. People realized that we don't have to be so aggressive to achieve the same outcome, and we're able to reduce complications associated with the traditional UPPP. Moreover, people realized that the area of obstruction behind the palate needs to be expanded in the lateral dimension. Hence, you can see that from 1981 to 2018, there are many modifications, including the uvular palatal flap, transpalatal advancement, lateral pharyngoplasty, as well as suspension techniques. All those surgical techniques and changes occurs as a result of us understanding that in a patient with sleep apnea, the soft palate is thicker, the swabbing is in an unfavorable position, longer, more lax, and there's some neural factor involved. And most of the time, it is a combination of all this that leads to sleep apnea. So what we're going to do with soft palate reconstruction is to achieve the desired morphological outcome with the correct dimension function during sleep while preserving functions during wake. If the retropalatal space is small, we want to make it wider. If it's long, we want to make it shorter. If it is collapsible, we want to make it stable. All in all, we're trying to normalize the soft palate for the patient. Now, if you look at the oral pharynx of a patient without sleep apnea, you realize how capacious it is. This is what we call a modified Mahampati 1 position, whereby the soft palate is in the correct position, the tongue is low down. You can see the oral pharynx clearly. But in the patient with sleep apnea, you realize that they are all of different morphology. So when we want to operate and reconstruct the soft palate, what we are trying to do is to make it as normal like what the patient without sleep apnea has.
Hence, we have to understand what each technique does to the soft palate in terms of its lateral and the EP dimension. And we have to understand what muscle constitutes the soft palate for us to do that, and what movement will allow us to achieve a stable and not collapsible soft palate. All in all, we have to choose the right tools that are available to us. I know it's confusing for non-surgical and non-ENT doctors to say, well, there's so many different techniques, which technique works. But as I teach all my residents, it's important for us to understand what each of the technique does and apply them to the correct patient.
Next, I would like to elaborate a little bit about robotic tongue-based surgery. We have this man to thank for it, Professor Claudio Vicini. He's the first to report the use of the Da Vinci robot in treating patients with sleep apnea by resecting tongue-based tissues.
In his report of 44 patients with sleep apnea, he showed that transoral robotic surgery can be used to effectively and safely reduce the tongue base in this group of patients with improvement in AHI as well as their sleepiness scale score. His report was followed up quickly by Michael Freeman's publication comparing transoral robotic surgery, radiofrequency of the tongue base, as well as smiles, a completion technique. And what he showed was that the surgical cure rate for TOS is significantly higher than the radiofrequency as well as smiles. And only the transoral robotic group achieved statistically a significant improvement in minimum oxygen saturation. Over in Asia, we also published our results using the robotic technique for patients with sleep apnea.
So what we found was that transoral robotic surgery with palatal surgery is able to achieve a cure of 35% in patients with sleep apnea and a success of 55% with a failure of 10%. At the time, we found that, patients can have subjective improvement in snoring, satisfaction, as well as ESS score. None of our patients then required a post-operative tracheostomy. And we concluded that, in transoral robotic surgery with palatal surgery for Asian patients, it is also a safe and effective treatment. As you can see, this is a setup with the patient at the surgical table and the surgeon at the console. I'm just going to let the video run for a while. As you can see, this is us trying to reduce the obstructive lymphoid tissue at the tongue base using the robotic arm that is able to reach far into the tongue base of the patient and removing the epiglottis partially. With so many publications coming out on transoral robotic surgery, we decided to do a systematic review and meta-analysis on it. And we showed improvement in all parameters, the AHI, the LSAT, and the Epworth Linear Scale. And that is independent of the BMI, meaning that there's no change in the BMI pre and post-op. Next, we're going to talk about advances in skeletal surgery. Well, we know that in patients with sleep apnea, skeletal issues can contribute to the pathophysiology of it. Hence, a proper clinical and cephalometric examination is necessary for us to find the correct surgical treatment for the patient. So in patients with skeletal issues, the maxillomandibular advancement has been shown to be one of the surgical technique and treatment that has got the best long-term outcome and cure. And even that has undergone changes such that, instead of pure advancement, the surgeons, we are doing rotational advancement to give the patient a better aesthetic outcome as well as to increase the posterior airway space with that advancement. So as mentioned, this surgical technique gives the patient the best surgical cure and success in the short and long run. Well, the next advancement that I'm going to talk about is hypoglossal nerve stimulation.
Next, I would like to talk a little bit about upper airway stimulation. This is over 20 years of research, disappointment, resilience, and hard work by the sleep medicine and sleep surgery community. What it is essentially this pacemaker-like device that's implanted on the patient's upper chest with an afferent loop that senses the patient's respiration and an efferent loop that stimulates the hypoglossal nerve, causing it to open up during sleep in patients with sleep apnea. And it has been shown to improve AHI, oxygen desaturation index, better quality of life, better snoring, and better function of sleep outcome for our patients. And what is amazing about this device is that you only switch it on when the patient is sleeping, and of course off when the patient is awake. And the researcher in this publication in New England Journal of Medicine was able to conduct a randomized withdrawal of therapy, showing that without the therapy, the patient's sleep apnea goes back to where it was previously. And now we have about 5 years worth of data in that it works for our patients. One of the major advancements in sleep apnea surgery is in the conduct of a randomized controlled trial in sleep apnea surgery research. And this was done by Daniel Fribert from Karolinska Institute. Essentially, what they did is that they randomized patients into two groups, one that received the modified UPPP and the other one is the control. And what they showed is that the patient who received the modified UPPP showed the improvement in polysomnographic results compared to those that didn't.
Further to the publication on polysomnographic parameters, they've also shown that in terms of sleepiness, blood pressure control, sleep quality, definitely with palatal surgery, it's better than those patients without surgical treatment. And these are all results coming from that randomized controlled trials. And with so many evidence supporting sleep apnea surgery, be it retrospective studies, case control studies, randomized controlled trials, basic science study, I think most of the sleep physicians and people who treat sleep apnea are onto the idea that sleep apnea surgery has a role to play in patients with obstructive sleep apnea. And what role can it play? Well, we can actually combine sleep surgery with CPAP to improve compliance and adherence. And a lot of studies have shown that in patients with nasal obstruction, after surgical treatment for the nose, we are able to initiate CPAP and improve adherence. Similarly, for patients who are already on CPAP but who are unable to tolerate it for the full 4 to 6 hours or 8 hours of sleep because of high pressure from the CPAP, be it from the nasal obstruction or a narrowed airway, upper airway surgery has been shown to reduce the amount of pressure that's required to stabilize the airway and also increase the time that they can use the CPAP machine and hence improve compliance and symptom scores. While we know that a lot of treatment does not cure sleep apnea or bring the patient's sleep apnea down to normal in all instances. Of course, if we have got a treatment like CPAP or mandibular advancement splint that's able to bring the sleep apnea down to from mild, moderate, or severe to the normal stage and sustain it over time, I think that would be great. But if let's say, for example, we are not able to do that, but we can combine all those treatments, be it sleep hygiene, behavioral treatment, positional treatment, CPAP, nasal treatment, surgery, MAS, or even myofunctional therapy, to bring the sleep apnea disease load down to a manageable level with improved quality of life and reduce long-term mortality. I think that would be the aim of treatment with patients for sleep apnea. And to conclude, sleep apnea is a prevalent condition with significant morbidities. Medical treatments are here to stay, and surgical treatments have evolved and will continue to, and surgical strategy will help us manage this group of patients, and multimodality treatments will improve patient outcome. With that, I thank you.